I have one disclosure to make. Lately, I have been serving on the advisory board of Baxter for their new formulation of a subcutaneous immunoglobulin replacement therapy named HyQvia. The objective of my lecture is to provide you helpful hints for the diagnosis and treatment of primary immunodeficiencies at the pediatrician's office. We will review the major groups of primary immunodeficiencies in regards of them grouping with either the innate or the adaptive part of the immune system. And within the innate part, we will specifically talk about complement and phagocytosis defects, whereas in the adaptive part, we will focus on T and B cell defects. On the second part of my talk, I will give you an introduction to the most frequent primary immunodeficiencies that are affecting antibody production. And here, we will review hypogammaglobulinemia, which could be either transient or persistent, selective antibody deficiency, RGA deficiency, and common variable immunodeficiencies. The last part of my talk will focus on the most severe type of immunodeficiency, which is called severe combined immunodeficiency. And I will introduce you to the newborn screening process and what treatment options we have for these patients. As a quick reminder, primary immunodeficiencies are called the inborn error of immunodeficiency because this is a disease that is genetically coded and present since birth. It is extremely important to emphasize it for your patients since there is a stigma in immunodeficiency in the community and people easily associate it with HIV or AIDS. Basically, these defects are causing an impairment of the immune system, and as I mentioned, they are genetically coded. Today, there are over 300 genes that we know that are associated with immunodeficiency. The underlying cause can be either familiar, running in multiple generations of a family, or de novo mutations when a patient is presenting with a new disease and a new mutation. The clinical illness may range from mild to severe, and initial presentation can happen early in life, but it is not uncommon now to see adults coming down with immunodeficiency presentation. As you can see in this graph, the number of immunodeficiencies have been skyrocketing, and just by the middle of 2010, we have over 300 immunodeficiencies following an exponential curve. So can we even consider it an orphan disease? We know that by 2021, there would be probably over 500, even close to 3,000 genetic defects associated with immunodeficiency. And that it has been established in the past that the frequency of PIDs in the general population is 1 in 1,200. So I question the fact whether this is still an orphan disease or if it is going to be an important and a relatively common entity. The population prevalence of PIDs have been nicely examined in 2007 by John Boyle and Dr. Rebecca Buckley. They were conducting a survey over 10,000 households where they asked them to report if there is any presence of immunodeficiency in the household. And 2.5% of the household did report the presence of immunodeficiency. Of these all reported cases in the left, 16% were actually confirmed with a specific diagnosis that is leading to the overall frequency of PIDs in 1 to 1,200 in all persons and 1 to 2,000 among children. As you can see, among the non-diagnoses, the most common one in this population study was CVID, common variable immunodeficiency, followed by IgA deficiency and IgG selective antibody deficiency. And this is our understanding or our knowledge that actually most of the immunodeficiencies that you will see in your practice will be related to antibody deficiencies. Why to diagnose PIDs early in life? We want to do that to expedite definitive treatment, since some of the more severe forms can be transplanted, and if it is transplanted in time, the outcomes are much better. Transplantation has been achieved for SCID, Wiskott-Aldrich syndrome, and CGD. We also can provide them early supportive treatment, which can be initiated with prophylactic antibiotics, and if needed, transition to immunoglobulin replacement therapy. As you can see, the cohort in the left that was reported by Dr. Buckley has been receiving IVIG or subcutaneous immunoglobulin treatment in a good fraction of the patients. When to worry about primary immunodeficiencies? Multiple flyers are giving us guidance now how to look for these diseases, and one of them is the 10 warning signs of primary immunodeficiency. As you can see, there are 10 distinct points that would guide you to how to worry about immunodeficiency, but let me just summarize them in certain pairs. The first one is that these patients have too many infections, including otitis media over 8 times, sinusitis more than 2 occasions, and pneumonia on 2 separate events in the patient's lifetime. The patient can also have repeated deep skin infections and persistent yeast infections. Beyond the many infections, most of our patients actually have unusual or weird infections. Just as an example, pneumocystis pneumonia is not commonly seen in a normal host, but has been highly associated with severe combined immunodeficiency and X-linked hyper-IgM syndrome. On the other hand, specific fungal infections such as Aspergillus, Nocardia, and Serratia is highly associated with chronic granulomatosis disease. Invasive mycobacterial disease and persistent yeast infections are also commonly seen in our patients. And I would like to bring it to your attention that if you have a patient with recurrent yeast infections affecting the oral mucosa or the nail beds, and they are resistant to treatment, you really should consider an underlying immunodeficiency. On the third point, a weird autoimmunity can occur in our patients, and this has been only known in the past decades. We can see patients with early onset autoimmunity or syndromic autoimmunity without any evidence of severe infections in life. And the patient overall may become infected with, again, very unusual weird organisms. And lastly, patients who have neonatal lymphopenia are concerning for an underlying immunodeficiency. And the magic number here is less than 2,000. I want to warn you that infants who have less than 2,000 lymphocyte count could appear normal on a laboratory slip that is coming from a laboratory that is looking at adult or adolescent patient samples. And therefore, I would like you to make sure that you are looking at an age-appropriate group and you are not deceived by an abnormal age range. What is the clinical spectrum of immunodeficiencies? As we have mentioned, infection can be the most important component or warning sign of immunodeficiency, but now we know there are multiple other features such as autoimmunity, severe or persistent inflammation, malignancy, and occasionally the persistence of severe allergies, and they all together can characterize a patient with immunodeficiency. Now we're going to move on and talk about the major group of primary immunodeficiencies. And in this regard, we will look at the complement, the phagocytes, B cells, and T cells. The innate immune system is the part of our body that is inborn and is nonspecific. This is going to form a first-line defense, and it does not require previous exposure. It is ready to go at the time of infection. Among the innate immune system, we will focus on 2 different deficiencies. One is related to the complement, and the second one is on phagocytosis. In case of complement deficiencies, early defects, including C1q and up to C3, present with recurrent pyogenic infections, mainly with encapsulated organisms. And curiously, these patients can actually develop severe glomerulonephritis and lupus later in life. Depending on the defect, it can range from 40 to 90% of the cases. The lead defects of the complement deficiency are more characteristic of recurrent Neisseria infections. If you have a patient with Neisseria meningitis, you have to consider a complement deficiency. Lastly, disrupted control of the complement may result in certain immunodeficient phenotypes, such as familiar hemolytic uremic syndrome or age-related macular degeneration. What is the laboratory test for this disease? You can send a simple CH50 test, and it will give you some guidance. If it is abnormal, we can go and analyze the components separately. Regarding the phagocytosis, neutrophil adhesion defects has been described in many of our patients. Neutrophils are very important in going to the site of the infection, crossing the vessels, and then going to the tissues. In these diseases, the neutrophils cannot adhere or cross the vessel wall, and therefore they are going to be absent in most of the abscesses. The patients end up with soft tissue abscesses or lymphadenopathy in many of the cases, and there is poor wound healing, chronic inflammation of the gingiva or the periodontal area has been noted. The test is relatively easy. Flow cytometry can be obtained for certain markers of these neutrophils. The type 1 disease is associated with abnormal integrins, CD11 or CD18, the type 2 with CD15, and type 3 is with abnormal platelet aggregation. The second part of a phagocytosis defect is called chronic granulomatosis disease, or CGD. In this case, neutrophils are present, but they cannot properly kill the organisms that they engulf. These organisms are merely catalyzed positive organisms, such as Staph aureus or Aspergillus. These patients not only have abscesses, but they can have osteomyelitis and chronic inflammatory bowel disease. The laboratory test, again, is flow cytometry, when we can look at the neutrophil oxidative burst, we can look at the actual function of the neutrophils and determine if they have a defect. On the other hand, adaptive immune system is more important in late response. It diversifies with age and exposure, but it is going to be pathogen specific. So these cells require a previous exposure to be 100% effective. And among those, we will talk about the B cell and the T cell defects. In case of the B cells, we just group these defects as antibody deficiency, and it's present in 50% or over 50% of all primary immunodeficiencies. The infections are merely recurrent sinopulmonary infections or chronic or recurrent gastritis, and in some cases, very specific cases, enteroviral meningitis. We also see associations of these diseases with arthritis or unexplained bronchiectasis. The laboratory test will look for the number and the function of the B cells. Number-wise, we can see either decrease of the B cell count or some of its subset. And regarding the function, we can see an age-appropriate immunoglobulin level that is decreased. It is very important to catch this patient early because sometimes the diagnosis can be delayed up to 2 to 5 years in childhood. The second level of testing that we recommend in this population is vaccine-specific titers. Curiously, the vaccines have different strength or provoking antibody response. Therefore, most of our immunodeficient patients have difficulty with pneumococcal responses, whereas they do quite well with tetanus and Hib. Regarding the T cell deficiencies, we group them as cellular defects. T cells are very important in elimination of viruses and fungi. Therefore, the patients will present with persistent viral infections such as warts, occasional herpes, or EBV. They can have fungal infections affecting the mouth and the nail beds, and occasionally malignancy. Laboratory test that we recommend is an actual T cell count, and we can arrange for T cell proliferation assays that would help us to understand how well the T cell react to an antigen or mitogen. And I want to warn you that beyond these common deficiencies, there are other deficiencies that actually affect more important signaling molecules or other elements of cell structure and movements. These patients, beyond T and B cell defects, will have additional features, such as in case of SED3 or hyper-IgA syndromes, patient would have facial dysmorphism, as you can see it in the left here, and bone abnormalities, and among them is the late dentition of teeth. Many of these patients, even in adulthood, will not shed their childhood teeth. Defective elements of cell structure and movement has been described in Biscott-Aldrich syndrome. In this disease, both adaptive and innate immune defects are present, but also the patients have very small and dysfunctional platelets. And this is one of the reasons why these patients present early in life with intestinal bleeding that can be easily confused with a milk protein allergy. Lastly, I want to give you an example of defective DNA repair mechanisms which can occur in severe combined immunodeficiency and its variant. Most of these patients have adaptive immune defects that include both T and B cells, since these are important enzymes that create the B cell and T cell repertoire. But also these patients have inability to repair DNA damage in some of the other cells outside of the lymphoid system, such as the neurons. And these patients would have seizures, microcephaly, and learning disability. They also curiously have a bird-like faces. So just to give you a quick summary, immune deficiency can be caused by multiple different types of infections, and the red flag should be up there. The laboratory testing that I recommended to you for these immunodeficiencies were actually affordable, and I listed you a couple of the different tests and their cost, so you will feel more comfortable about ordering it for your patients. And this chart nicely summarizes this information that has been kindly provided to us by Dr. Troy Torgerson from the University of Washington and Seattle Children's Hospital in Seattle, Washington. So let's move on to our second part of our talk when we talk about the most frequent primary immunodeficiencies, which are the antibody deficiencies. As you can see on this pie chart, when they looked at the distribution of primary immunodeficiencies in a tertiary hospital, predominantly antibody deficiencies were the largest part of the pie chart. We will talk about specifically the inability of B cells to make immunoglobulins. B cell development is a very tedious process. It is starting in the bone marrow, and B cells that mature in the bone marrow will eventually move out to the periphery by the blood and reach to the spleen or the lymph nodes when they further mature. In the initial phase, they are highly dependent on the VDG recombination machinery, and if it is affected, patients will end up with severe combined immunodeficiency or other variants of it. The second part of B cell development is highly dependent on an enzyme called BTK, or Bruton tyrosine kinase. This enzyme will influence B cell signaling, and its absence will result in the full absent development of B cells. The initial defect was described as X-linked Agammaglobulinemia, or XLA, but now we know that they are autosomal recessive form of this disease as well. B cells that successfully leave the bone marrow can go to the spleen or lymph nodes and eventually be committed to certain isotypes. These class-switching defects can occur in the spleen and result in hyper-IgM syndromes. During my talk, I am not going to focus on this disease since it's a very rare and specific entity. But I want to emphasize you that final B-cell maturation defect can occur in multiple immunodeficiencies. Among those, the most common one is common variable immunodeficiency, selective IgA deficiency, and selective IgG antibody deficiency. And I will give you some details on these diseases. Agammaglobulinemia has been described in the last century, and it is clinically presented by early sinopulmonary bacterial infections, occasionally chronic enteroviral meningitis, and what gives a clue to the clinician is the absence of the tonsils on the lymph nodes on the exam. As you can see on this cohort of over 23 male patients, beside the upper respiratory infections, patients can also have gastrointestinal infections, sepsis, meningitis, and other type of infections. Laboratory test is relatively easy. Most of these patients have either absent or very low number of B cells. And this is key to the diagnosis since the immunoglobulin levels can vary. They are either, generally low for IgG, IgM, and IgA, but there is quite a bit of a variability in this front. Genetic testing and flow cytometry can be arranged for the defects in XLA. And treatment mainly includes IVIG or subcutaneous immunoglobulin, and you would like to give it as early as possible. Just to give you an example of the autosomal recessive defects, anything that is related to the immunoglobulin molecule that is sitting on the surface of the B cells early in its life would be able to cause agammaglobulinemia, and that may include the alpha and the beta chain, the lambda 5 and the kappa element, and even other signaling molecules such as Blink. And here is BTK, that is the X-linked version of the disease. This is a nice pie chart that shows that most of the cases are X-linked agammaglobulinemia, but the other diseases are also relatively common. The most common early form of immunoglobulin deficiency is called transient hypogammaglobulinemia. In these cases, patients have early sinopulmonary, mainly bacterial infections. This could be transient and could be improved by 2 years of age. On the laboratory side, we can find normal B cell subsets, but in a fraction of the patient, low switch memory B cells or mature B cells were noted. The functional studies show low IgG levels, but no non-genetic mutations have been or associations have been explored for this patient group. Treatment choice on the first line is prophylactic antibiotics, and in the second line is transient immunoglobulin replacement. As I mentioned, most of these patients improve by 2 years of age, but some of them remain longer, and these patients tend to have a history of food allergy or autoimmunity. Selective IgG deficiency or vaccine titer immunodeficiency has been described in also some of our young patients. The patients similarly present with sinopulmonary infections, and they have normal B cells, occasionally low mature B cells. In these patients, IgG levels are actually normal, but they have low vaccine response, even after repeated immunizations. As I had mentioned to you, among the vaccinations, pneumococcal titers seem to be the one who wane faster and decline faster. There are no non-genetic associations for this disease, and treatment is similar to the previous entity. First line is prophylactic antibiotics, second line is transient immunoglobulin replacement therapy, and it may improve with age. The third version of the antibody deficiencies, and this is actually the most common, one of the most common immunodeficiency, is selective IgA deficiency. The patients can present with sinopulmonary infections, but there are cases with no history of infections. Curiously, this IgA deficiency can frequently be associated with autoimmunity and occasionally with autoimmune gastrointestinal disease, such as celiac disease. The laboratory evaluation will reveal normal B cell count, but low or absent IgA with no non-genetic associations. Treatment is similar, including prophylactic antibiotics or immunoglobulin replacement, and it may improve with age. Actually, there's a natural improvement of IgA levels in life, so there are children who are born with low IgA level and eventually improve these levels by 2 to 3 years of age. Among the antibody deficiencies, the most severe and most important one that I consider the most important is common variable immunodeficiency. This is actually an umbrella term because it includes any kind of patients who have a diagnosis of recurrent infections, low IgG with IgM and or IgA levels, and inadequate response to vaccinations. But again, you have to exclude other form of hypogammaglobulinemia before you decide to term the patient as common variable immunodeficient. Clinical presentation is mainly with recurrent infections, and it can actually occur anytime in life. There are patients who are presenting with recurrent infections only in adulthood. The spectrum of autoimmune disorders have been recently explored, and really we showed that the autoimmune disorder is an important component of the disease. Laboratory testing is notable for low T and B cell numbers or function, low IgG levels with low IgM or IgA. Most of these patients have inadequate response to multiple vaccinations, and we have non-genetic causes for around 20% of the cases. Treatment-wise, we want to treat infections, and you can avoid infections with the use of prophylactic antibiotics and or immunoglobulin replacement. But autoimmune complications may actually need immunomodulation. And this is a significant challenge for the practicing clinician, since immunomodulating an immunodeficient patient can provoke more severe infections. The goal is to avoid severe bacterial infections, and for that reason, sometimes the IgG dose has to be adjusted. What are the side effects of immunoglobulin replacement? I have mentioned to you now that we are using it for most of our antibody-deficient patients, and some of them do develop severe headaches and sign of aseptic meningitis. In 10% cases of the low-dose treatment, and we occasionally use high-dose immunoglobulin treatment for anti-inflammatory properties. And in our population, 30 to 50% of the high-dose cases can develop this headache and aseptic meningitis. Many of them can improve if there is change in the product, and we can also prevent it by lowering the infusion rate or using proper pre-medications. Prehydration can also improve this headache. And what has been known that if there is family history or personal history of migraine headaches, it is going to pose a higher risk for the onset of headaches and aseptic meningitis. Other side effects include anaphylaxis. Anaphylaxis or severe allergic reaction is a contraindication for IVIG or sub-QIG preparations. Sometimes IVIG preparations are not as well tolerated, and the patient will do well with the subcutaneous version. It could also be related to anti-IgA antibodies that are present in patients with no IgA. But for now, the reports from around the world says that it is only occurring in a handful of cases. In some of the cases, we can see hives and chills, and they can be prevented by slower infusion rate or proper pre-medications. Now I would like to talk to you a little bit about the complications and outcomes of CVID. A recent study from Europe has shown that among over 900 patients, that 34% of the patients will present with less than 10 years of age. And beside pneumonia, autoimmunity is the second most common complication of CVID. Close to 1/3 of the patients would have autoimmune complications. But we also know that patients who have autoimmune complications or other non-infectious complications will have increased mortality, as you can see in the chart in the right. Therefore, it is very important to identify patients with CVID and to recognize their non-infectious complications in time and treat it. What kind of autoimmune complications can we see in CVID? Mostly we see autoimmune cytopenias, ITP, Evans syndrome, autoimmune hemolytic anemia, or neutropenia. But you can see that the list can go very long with other less frequent complications. And just to give you an example, features of autoimmunity has been present across the board in all primary immunodeficiencies. It could be hematological, as I mentioned to you, but there are certain immunodeficiencies that have very specific autoimmune features with the endocrine system, such as diabetes, hypo or hyperthyroidism, and adrenal disease. Some patients have autoimmune diseases of the gastrointestinal tract, the neurological tract, the pulmonary system, and the skin. And to give you an example, one of the most feared complications of CVID is the infiltration of lymphocytes in the lung, called granulomatosis lymphocytic interstitial lung disease, or GILD. These patients have a really hard time and would end up with not only infections but very narrow pulmonary function and would need immediate intervention. Otherwise, the mortality rate can go very high. So the last part of my talk is to talk about the most severe form of primary immunodeficiencies, which is termed SCID, or severe combined immunodeficiency. Among all the diseases you mentioned, this is the only one that is truly a medical emergency, and these patients should be identified as early as possible in life because the outcome can be heavily impacted by the onset of diagnosis. SCID is, in general, a cellular and humoral defect that is primarily secondary to the T-cell production or function defects, although T-cell production and function can be associated with secondary defects in the B cells or natural killer cells. The biggest challenge in the diagnosis of SCID is that early diagnosis is not easy. At birth, most of the patients are well appearing, like this very cute child on the picture. They get protections of maternal IgG up to 6 months of age, and therefore the mean age of diagnosis is still 6.6 months at the time of when Dr. Buckley reported a report in 1997. So even if our technology is improving, the diagnosis is delayed because the patient is protected up to 6 months of age. Clinical features at the time of diagnosis can include the weird infections that we have discussed, including oral candidiasis, parainfluenza infections, PJP pneumonia, adenoviral infections, gram-negative sepsis, and some of the patients have constant persistent diarrhea and difficulty to thrive. We can actually induce patients to get into this stage by vaccinating them with live viruses or bacteria. BCGosis is a common problem in the developing world. In this picture, you can see a child who had BCGosis after BCG immunization. Polio can cause severe impairment and the spread of the disease in these patients. And furthermore, now we have rotavirus immunizations in our country, which is a live vaccine and could potentially harm these patients. We know that infection is a risk factor for the mortality of SCID patients after bone marrow transplantation. Therefore, we would like to identify them before they have the clinical features of infection. The other challenge in the SCID population is that they are extremely heterogeneous. There is a wide variety of immunological phenotypes, including B and NK cell numbers, genetic phenotypes, and clinical phenotypes. And just to give you an example, the immunological spectrum of SCID can be very variable. As you can see, all patients have an absence of T cells, but depending on whether B cells or NK cells are present, you can have fold permutation of the disease. And all fold permutation has certain genes associated with it. In case of T-, B+, NK- SCID, the defect is mainly affecting T and NK cell specific pathways. When only the T cells are affected in SCID, T cell specific pathways are affected. Whereas in the full absence of T cells, B cells and NK cells suggest that these patients have toxic metabolites in their lymphocytes with time, and they have early stages of defect that would affect all line of lymphocyte development. Lastly, the patient group that has absence of T cells and B cells but not NK cells are going to be caused by genes that are important in generating the T and B cell repertoire and DNA repair, as I mentioned to you in the past. But what we know that it is always true that SCID patients have a low absolute lymphocyte count. And this is a very easy and simple test. As I mentioned to you, infants, around over 80% of the infants with SCID have a low ALC below 2,000. And it is common across the board. The hallmark of the disease is low ALC less than 2,000, T-cell lymphopenia, and low T-cell proliferations. How to diagnose SCID? Until now, we really relied on the clinical presentation of infections and failure to thrive, the family history, and the laboratory profile. But we think it's actually too late. So in the past 8 years, a new next-generation diagnostic modality came up, newborn screening for SCID. And it is going to utilize a very specific part of the T-cell development. When T cells undergo development in the thymus, the receptor is rearranged. And the most powerful tool to track this rearrangement is actually byproducts called TRECS, T-R-E-C. They are either signal or coding and TRECS. And these TRECS will stay in with the T cells. They are generated during development of TCR alpha beta T cells in the thymus. They can dilute as the cells replicate. And they were identified as the measure of thymopoietic activity in the 1990s. The original reason for the development of this assay was to look at the thymus of patients who were infected with HIV and see if they can actually still generate T cells. But this assay was nicely applied to the newborn screening for SCID by Dr. Jennifer Puck in 2005. Eventually, it was reviewed, and the screening study started in 2008 in Wisconsin. Since then, nationwide screening was recommended by the Federal Advisory Committee, and now it has been endorsed by the HHS Secretary. So this has been a long road, but an amazing historical road, when our country was among the first one who implemented this newborn screening. And what do we do actually? We use the dried blood spots from the newborn screening card and just punch a tiny little hole that would be used for DNA extraction. Once the DNA is extracted, the TREC that I mentioned to you will be amplified by a technique called RT-PCR and eventually analyzed for the presence of the number of TRECs. Why is SCID eligible for newborn screening? We know that the incidence is at least 1 to 100,000, and I have to tell you, since newborn screening has been implemented, now we know that the incidence in certain states can be as low as 1 to 50,000, which means that prior to the screening, we actually miss every second child with this disease. We know that this disease is fatal without definitive treatment, and early treatment improves outcome. We have a robust and feasible test, and there is a reasonable false positive rates. So because of all these arguments, SCID newborn screening has been implemented now in multiple states. And I just want to give you a couple of examples of children who have been identified and transplanted secondary to newborn screening, and you can look at their story at the CDC website. What is the treatment strategy for SCID? We can either give them enzyme therapy for replacement, or these patients can undergo definitive treatment with hematopoietic stem cell transplantation. And what we know from the beginning of 2000, that the younger the patient, the more likely the survival will occur. So if patients were transplanted below 3.5 months of age, they had an almost 100% survival up to multiple decades, whereas patients who were transplanted over 3.5 years of age had a much lower survival curve. Initially, it was only thought to be age-related, but what we have shown, and Dr. Sanyang Pai has shown in the New England Journal of Medicine just this year, is that it's not so much related to the age, but to the presence of infections. She compared groups of patients who were older than 3.5 years of age but no infections, and they had the similar really good outcomes similar to the patients who were younger. So we think that infections are probably the key players in outcomes in transplantation. And we also have gene therapy trials. These are research trials when we actually can correct the patient's own stem cells. And these patients are mainly the ones who have X-linked SCID with the common gamma chain defect. SCID newborn screening as of October 2014. It has been implemented now in 24 states in the United States. You can see it in blue. And 19 states are pending in purple. Public Health Department coordinates further workup for the positive cases. The confirmed positive cases that are below the threshold will have a referral to immunology, and you may get a phone call from the Public Health Department that your patient had a low TREC and needs to see immunology. But you can reassure your patients that only a small fraction of the screened positive cases are actually SCIDs, and the majority of patients will actually have T-cell lymphopenia of multiple causes. As SCID newborn screening may identify beyond SCID some conditions such as low T-cell compartments. The most common ones is T-cell impairment with DiGeorge and Down syndrome. You can see that those are the most common cases based on a recent report in the Journal of American Medical Association journal by Antonia Kwan. The patients who have also low T-cell counts could have secondary decrease in T-cell count secondary to cardiac defect or multiple congenital anomalies. And the most exciting part of the newborn screening to me is the unspecified T-cell lymphopenia patients. It's a relatively large fraction, over 100 cases from a total of 400 T-cell lymphopenia cases. And we have no idea about these patients and how they're going to evolve. There's a known entity of T-cell lymphopenia in adulthood, but it has never been described in cohorts of patients in childhood. So it is going to pose us a very interesting clinical question that was unrevealed because of newborn screening. So in summary, I gave you some helpful hints for the diagnosis of treatment of primary immunodeficiencies at your office. We talked about the major groups of PIDs that either affect the innate or the adaptive system, and I specifically talked to you about antibody deficiencies. I also mentioned to you about severe combined immunodeficiency. Even if it is a rare disease, because of newborn screening, you will hear information on it. And I would like you to be informed so you can inform your patients and parents as well. We heard about the newborn screening process and treatment.